Really pleased to be joined tonight by Helen Hughes and Alison Leary, Professor, who's a guru in all things workforce, and Helen, who's a guru in all things patient safety. So I might just get you two to introduce yourselves. So Helen first.
Hello, lovely to be invited. I'm Chief Exec of Patient Safety Learning. I've got a bit of a presentation, so I'll tell you a bit more about that there, but I'm just delighted to be here. Thank you for inviting me.
Thanks, Helen. And Alison?
Hi, everyone. I'm Alison Leary. I'm a Professor of Healthcare and Workforce Modelling at London South Bank University. And I've done lots of different workforce modelling projects, including the modelling for district nursing workforce standards for the QNI.
Brilliant, thank you. And I'm just going to introduce Helen Tucker, who's president from CHA, who's going to give us a wave. And Eleanor, who is the administrator for CHA, who some of you may have had email contact with. So, and I'm Evelyn Prodger. I'm the chair of the CHA. I'm a nurse by background with a long history in community hospitals, and one of the people who has grappled with safer staffing in them for quite some time. I'm so really delighted to be able to facilitate the discussion tonight. It would be great if you could keep your mic off while you're not speaking, just so we don't get any feedback. Please do put any comments, any questions, or any resources, links to resources, things like that in the chat box as we go. So we're going to have a presentation from Helen, we're going to hear from Alison, and then we'll have plenty of time for kind of questions and answers. So yeah, you know, hope you really enjoy this. I think it's a discussion we've all been looking forward to. So over to you, Helen.
Hello. Well, I have a presentation, but I've got two comments to mention beforehand. One is when I worked in the NHS, I never worked in the acute sector. I only worked in the non-acute sector. And my first director role was in community health services. So I come with that knowledge base, but I've been out of it for a while. The second point is that I've got massive imposter syndrome on the same panel as Alison talking about safe staffing. My goodness, there's no way I can kind of compare with Alison's knowledge, and indeed all of you have got much more practical knowledge than I have about these issues within your environment. But I thought what might be helpful, and Evelyn was kind enough to say that it would be helpful, will be to set some contextual information about, well, patient safety learning a little bit, so you know about us, but about the context. And really, I think, as I put in my email to Alison and Evelyn just beforehand, I'm the warm-up before you get to Alison, because she knows the stuff. So with those caveats, I'll start my presentation. Do you want me to share it, Evelyn?
I'll share it, Helen, if that's okay.
Oh, you've got it already, have you?
Yeah.
Oh,
yeah.
Super, good, because then I can see you. So I will try and keep it, you know, well, it might be a bit more like 10 minutes, but I won't talk too much. And apologies in advance. I've got a chest infection that is a bit of a bugger, and oh, sorry, that's recorded, isn't it? So I might be spluttering a bit, but yeah. So the second slide is just who are we at Patient Safety Learning? And I don't know if you're aware of us. We're a charity. We've been going about 4 years now, and we talk about ourselves as an independent voice, particularly around patient safety. And the Venn diagram is, it basically, the left-hand side is charity stuff. That's what charities do: campaigning, influencing, awareness raising, more good stuff, less bad stuff. And on the right-hand side is increasingly we're moving more to help people make patient safety a reality. So sharing knowledge and good practice to help not just call for improvement, but to enable people to make some of those changes. So next slide. And just the scale of unsafe care, you're probably all very familiar with this. We talk in the NHS, particularly in NHS England, of about 11,000 avoidable deaths a year. We've been using that statistic for about 20 years. And I would say post-pandemic, I don't know, What are those figures? Could be double, could be triple if you believe the Royal College of Emergency Medicine and look at excess deaths or avoidable deaths because of the crisis we have in emergency care. So we know it's a big problem. We know it's a global problem, and 3 million deaths each year worldwide as a result of unsafe care. It's morally the wrong thing to do if we can prevent avoidable harm, but it costs a lot, not only in terms of personal cost, social cost, but cost to healthcare system. It's expensive getting things wrong because you then have to fix it. So OECD figures suggest that 15% of healthcare costs are attributable to unsafe care. So if we could only take half of that and reinvest it, we could make a big difference. So the question we ask ourselves, or we've asked at Patient Safety Learning, is have we normalised an unsafe system, the way we operate as a safety system in healthcare, if we're not making those fundamental inroads in improving and reducing avoidable harm? What is it that we're not doing right? So next slide, please. And we produced a policy document called the Blueprint for Action, which is a call for action rather than just a policy. And we can send you all the kind of links for this. But at the heart of what we think is important in responding to reducing avoidable harm is putting safety as a core purpose. And that sounds quite glib and it sounds very obvious. And you get lots of organisations saying, oh, safety is at the heart of everything we do. And then you ask them what their safety plans or their strategies are and how they're going to make improvements. And people say, oh, well, we haven't got money for that. So there's some, both at a national level and local level, disconnect about what we hope we want to do and actually what we are doing about it and how we're resourcing it. And some of that is frankly a lack of leadership commitment. So there's an expectation that clinicians will be leading on patient safety, or patient safety managers will be leading on patient safety, but not necessarily, it's not really high priority for boards, or even, you look at the Hughes review that's just come out this week on ICSs and ICBs. Yeah, nothing on patient safety, as if it's kind of a given, it'll just happen by itself. So what we've called for in the Blueprint for Action is a number of actions. And this is emphasised and reflected in the National Patient Safety Strategy. But what we call for is a bit more than what's in that national strategy. But you'll be familiar with some of this about bringing the expertise in around safety and human factors in particularly, and safety systems thinking, critical importance about patient engagement and co-production, and that we're learning about safety improvement, not just from when things go wrong, but when things go right, and designing resilience in. And critically, when we're designing for safety and not just addressing the harm, it's critically important that we have a just culture that is psychologically safe for people to raise concerns, to suggest improvements. And without that framework, as we've seen from recent staff surveys, over 50% of staff in many organisations, most organisations, saying they don't feel confident about raising concerns, and even more than that, feeling that nothing will happen anyway. So that is not an indication of a safety culture that would give us confidence to be a patient or family member, or indeed to be a member of staff working in that culture, if you're not provided with the tools, the environment, the support to get things right. Things will go wrong. And if you're in a blame and toxic environment, that's not a comfortable place to be, for sure. And I set these out because they're all informing the environment in which people are working and the reality around the staff experience of work and the conditions they're in, which provides the context for looking at issues around workforce capacity, safe staffing levels. So one of the key points, and I've heard Alison say it as well, is that you can't just look at safe staffing in isolation from all these other things. They're not kind of singular parallel processes. You've got to look at a safe organisation. So next slide, please. So we've been doing some work in patient safety learning about turning those ideas into standards and what good looks like as a framework. So I'm not going to dwell on this, but if anyone wanted to know a little bit more, you can find out from our website how we're turning the good practice and working with organizations to embed the good practice by enabling people to self-assess against where they are. So if you're going to make improvement, it's always a good idea to know what your baseline is, what you're good at, what you're not so good at, and then help prioritize your improvement journey. So we've been doing some work on that. So I leave that with you and move to the next slide. And last year, the World Health Organization, or the year before, talked in the Global Patient Safety Day, which is now an annual event, about staff safety and patient safety being two sides of the same coin. And I think that's a really important key message, that that in looking at staff safety, which is an important element to consider when you're looking at kind of workforce capacity planning, so forth, that you're considering the impact that staff security, both physical safety, psychological safety, is having on patient safety. So they are intermingled, and physical safety, I mean, obvious examples during the pandemic around PPE. Psychological safety, I've already referred to the staff survey and the results that came out a few weeks ago, and we've blogged quite a lot on that, about the impact that has on the likelihood of patient safety problems being identified, reported and addressed if you're not in an environment that supports you and your colleagues to raise concerns or suggest improvement. And then the importance in terms of safe staffing levels, about safe and effective care, but also to protect staff from burnout and their personal well-being. And looking at that, I think in terms of safe staffing, not just in terms of an organizational perspective, but looking at it across the whole of the care pathway. And I think I'll come back to that in a second. So next slide. So have we got safe staffing levels? This was, again, I've drawn on from the staff, NHS staff survey results here. And you're probably familiar with this with your own organisations, I hope so. But I mean, this chart reflects it across a broad range of organisations, but it includes community as separate organisations as well as integrated. And this is self-reported. So just under 30% of respondents from community trust said they have enough staff at their organisation for them to do their job properly. So it is something that is it is a particular problem, and it's getting worse. And I will leave Alison to describe in more detail, but it's not just the numbers of staff, it's the staff with the right skills in the right place at the right time. Next slide. So this is me joining the Alison fan club here, and as I was pulling this together, there is ample evidence about the negative impact on patient outcomes as a result of insufficient staffing level. And it's been known. It's 10 years now since the mid-staffs report. We've got a patient safety learning. We've got a piece in this week's Royal College of Physicians newsletter, looking at what have we learned from mid-staffs and how have we implemented the recommendations, and have we implemented the recommendations, and how would we know, because no one's really monitoring it. So very, very clear links between safety incidents and staffing levels. But this really complex interrelationship between nurse staffing and various factors of patient safety. And I won't tread on Alison's toes there, but it is that reinforced message that you just can't look at staffing in isolation. You need to have the wider operational safety perspective to take these into account. So next slide, please. And then I've just drawn on, that this is, and I've drawn on my research from Twitter. Isn't that a well-established research method? But Dr. Steve Taylor, who does demonstrate his source. I mean, I saw he tweeted on this about, I think it was about 2 or 3 weeks ago, and I thought this was a horrendous set of statistics, and just increase in in terms of community healthcare, so not just a community hospital, obviously a broader range of service, but if you look at the increase in population numbers, probably population requirement, and then the number of staff that have gone down, that has been reduced in that time. So if you're, we're talking about workforce crisis, lot spoken about in acute care, but really these are alarming statistics. And so I don't have any magic wands here, but I am reflecting back some of what I've been picking up, that it's clearly an issue here in England. But this was actually, there's a global health workforce and health event that's been happening this week at WHO, and Dr. Tedros there, who's the Director General, talks about an estimated shortage of 10 million health workers in 2030, and the point he makes is it's pointless having, he actually used this phrase, having stuff or tools if you don't have the staff. So you can plan for whatever you like, but if you don't have the right people with the right skills at the right place at the right time, you're not going to be delivering the safe and effective care that we need. Next slide. And so we when we've talked about in our blueprint for action, we've talked about, excuse me, the need for a fully funded NHS workforce plan, and you'll have all read the headlines about whether there is going to be a workforce plan, how important it was to Jeremy Hunt when he was chair of the Health and Social Care Select Committee. It seems less important possibly now for him when he's Chancellor, but we haven't yet got a fully funded and costed workforce plan. It's imperative that that's at a system level, but also at a local level in terms of workforce planning, and that those staffing levels reflect patient acuity, staff ability, skills, models of care, the local context. Rough and ready, easy ratios and targets aren't sophisticated enough to meet our needs here. And then what has been leaked from the prospective workforce plan, and this was sourced from the Guardian, they've said they've seen this draft workforce plan, is a 55% increase in staffing by 2035. Now that's on the basis of 154,000 staff vacancies at the moment, and with some suggestion that there might be 500,000 vacancies by 2036. So all these figures are pretty alarming, obviously. Next slide. And so what are other people doing about it? There's certainly the recognition that it is a global issue, that I haven't read it in detail, but impressed that at least Canada are actually doing something and are publishing stuff. So I don't know how good it is, but they are persuasive in that what they're not doing is just focusing on recruitment, which seems a very superficial approach that is well liked by many politicians and healthcare leaders here, I think, in the UK, or certainly in England, which is, and if you've got a leaky bucket, then before you start pouring water into it, you need to stop the leaks. So the issues of retention and support for staff, why are we losing so many good staff? Why are we recruiting? I think it's in terms of, I haven't got community hospitals figures, but in terms of midwifery, of 29 midwives we train, within 2 to 3 years, we've lost all bar 1 or 2. So there is something fundamental about how we're bringing people into the workforce, but not able to retain them to enable them to undertake their skills. So what is it about how we support staff, how we create a culture and enable people to do the work that they are professionally committed and trained to? What is it that we're doing that means that people are leaving in droves? Next slide. So yeah, I told you fandom. I don't know, the specialist nursing presentation that you did, Alison, was absolutely excellent, and it is, I know it focuses on specialist nursing, but the understanding the complexity of the environment, particularly for nursing, obviously in this regard, but the issues to take into account in designing the workforce. probably one of the best presentations I've come across. So we have put it on the hub, and we've got quite a lot of resources on the hub. So I would commend people to access that. Next slide. And in terms of accessing information, one of the ways that we aim to support people in understanding about risks of avoidable harm, but how they might address those, is to share knowledge, and we do that through the hub. It's a not particularly imaginatively titled learning platform for patient safety. It's free for anyone. I mean, it's so we talk about promoting the voice of the patient safety frontline, and by that we mean frontline staff, clinicians, people working in patient safety, patients, families, caregivers, and we share peer-reviewed literature, blogs, lots of content, news and community. So that's all available for people to use. And if you could go on to the next slide. That's some of the stats since we set it up about 3 years ago. It's had about 1.3 million page views now. In terms of people from over 200 countries are accessing it. Lots of knowledge resources, lots of communities of interest to engage with. Evelyn will know very well about the Patient Safety Management Network that is very vibrant. That's got 950 members with a weekly drop-in session where people share experience. We bring experts in. It's led by and for people working in patient safety, so you're all very welcome to join that. And as you can see, in terms of the membership, it's healthcare leaders, it's clinicians, it's commissioners, funders, a whole range of people, everyone working to the common goal of trying to improve patient safety. Next slide. And that's the last one for me, which is basically there's some content there about how you can get hold of us, what we're doing on LinkedIn, and particularly accessing the hub. We've got a number of sites on the hub specifically about safe staffing, where you'll see research evidence, good practice, and we'd love to strengthen that. So more resources on there, just let us know, we'll put them on there. But I hope you find it helpful, and that's been a decent enough introduction to you, Alison.
Thank you very much, Helen, and I don't think imposter syndrome should have a place, because that was really helpful and really informative, and you know, I think we really do see the patient safety and the safer staffing as two sides of the same coin, so really important to have that context. And I really like that you talked about the wider operational context, because I think that's always been the struggle for community hospitals. There's always lots of guidance around acute, and there's lots of guidance around primary care, and community hospitals are often left somewhere in the middle, trying to work out which bit of which guidance fits with them. And often, you know, they're smaller, they're standalone units, although they sit within a bigger organisation on the whole. You know, so they do have a kind of unique set of circumstances and a very different context. So really good to hear that reflected. So over to you, Alison.
Thank you, and thank you, Helen, for those kind words. I'm not sure I can follow that now. So I don't have any slides. I thought I'd just maybe generally talk a bit more about the principles of workforce modelling and, you know, about work. So Helen's right about the issue around safety. So workforce and safety in healthcare are seen as two different things. So we put safety over there and we put workforce over here, and that's the business of somebody else. And the two rarely actually meet as they would in other safety critical industries. And there's a very famous safety researcher called Eric Holnagel, and he says that in healthcare, safety is not income generating. So in a lot of the industries that I work in, safety would be very income generating, like the aviation industry, because if you crash your planes, people won't get on them. But quite often healthcare absorbs very big safety catastrophes that are often related to workforce with very little consequence. There might be a report or an inquiry, but we are 10 years on from Francis and very little has actually changed. if anything, we're seeing degradation in the workforce rather than improvements. And yet Francis did very much link safety with workforce. If you go back to the Ely Hospital inquiry in 1967 and the 50 years worth of inquiries we've had since then, including community, so Winterbourne View, and particularly learning disability and autism, you see the same themes coming up again and again. So it is numbers of people, but primarily it's about the education and skill level of people. Quite often these organisations have diluted their workforce with lots and lots of workers that perhaps don't have the right skills, experience or training to do the work. They also cite leadership as a common theme, and also the joining up of care. So the coordination of care planning is quite often missing. And we also see that when we look at coroners' prevention of future death notices. In fact, we did an analysis of coroners' prevention of future death notices in England and Wales, about 700 of them, including the community. And we found that the lack of coordination of care, so lack of care planning, missing or lack of joined up care, was the most cited concern by coroners in those notices. So you can see how there is a complex but very evident relationship between workforce and safety, and that's particularly the nursing workforce, but it's not exclusively the nursing workforce. So in nursing particularly, there are standards now. So although there is nothing that I know of specifically for community hospitals, there are the RCN workforce standards now. Some of the other professional associations, so the AHP type organisations, also have workforce guidance, at least. None of them is particularly for this environment, and that makes it quite challenging, I think. So what do you do if you don't have specific guidance? The thing that we generally do in an organisation, so this is what we did for district nursing, because they had none either, is to think about demand for labour. So in the NHS particularly, the workforce is designed on what we call a demand and capacity modelling basis. So it's based on activity, how much work gets done, how many tasks get done, how much activity gets done, how many patients go through. But that's not always a good proxy for demand for labour, and particularly in relational work. So particularly in areas like long-term conditions management, where for a period of time apparently nothing happens, but actually something is happening. Rehab, areas like that. That form of modelling underestimates workload. And the reason for that is that we commonly say, so this is the work of people like Jennifer Jackson and Davina Allen, that nursing particularly encompasses 4 types of labour. So there's the task and activity type work, the stuff people measure, the physical labour. But there's also cognitive labour, and that goes across all the professions. So people have to think about stuff. And if you don't give them time to do the thinking and the processing, then they burn out. And it's why people like air traffic controllers have lots of breaks, and lorry drivers and people like that, and tube train drivers, because of the constant concentration. And we've seen a lot of evidence that working things like 12.5-hour shifts increases fatigue and decreases concentration. There's also emotional labour, relational labour. So the fact that, we have to relate to other people as part of the work. So that's Pam Smith's work from a very long time ago, from the 70s. And then for nursing particularly, there's organisational labour. So nurses organise a lot of work, and they organise the work of others too. So when you think about how you calculate the workforce, if you only look at that first one, that task achievement type of activity, then you're not calculating the need for labour. Healthcare also works on what we call a supply side model. So the healthcare workforce is designed primarily around who we can afford and how many people want to train, not the actual demand for labour. The result of this means that there is a deficit in labour. So it means people work unpaid overtime. Generally, that's how it's manifested. We're also seeing what we think of as workload intensification, and people not being able to use their labour productively. Workload intensification is caused by lots of different things, different complexities of pathways, IT that doesn't work very well, and what it ends up, and policies actually. And what it means is people have to do more things to achieve the same results, have to expend more labour to get to where they need to be. There's quite a lot of unproductive labour in areas like nursing. So in acute nursing and in, see, Crystal, I would get a lot of trouble with Crystal Oldman if I referred to acute and community, because she says acute is in the community now. And actually, I think she's right. So I'm not going to say that. I'm going to say hospital and community in future. Because actually, when I went to district nurses, there were some really sick people, actually. And actually, when you go to nursing homes, there's really sick people in them. They were in ITU when I was younger. So when we think about that extent of labour that's required, it's actually very, very complex. But people have unproductive labour, so they're spending a lot of time doing on things that isn't resulting in an outcome. So, and there's lots of those. One of the really big ones that we see across nursing and medicine particularly is administrative work, a work that perhaps a skilled clinician doesn't need to be doing, that somebody else could be doing, and therefore that's unproductive time for them. But the work still needs to be done. The response quite often from employers and policymakers is to introduce what we call a Christmas tree model. And a Christmas tree model is where you have a professional, and then you supplement that professional with lots and lots of lower paid, perhaps lower skilled workers. So the response in nursing, and now we're seeing this in the AHP world, is to introduce more and more and more support workers. But this is a double-edged sword. So I've just been analysing some data on this recently. And what we're seeing is that frontline skill dilution is actually a trigger for people leaving. Because now a registered professional, so if you invert that Christmas tree, the pressure is now right on that professional with the pin to supervise lots and lots of other people's work and be responsible for it. And that is actually a trigger for people leaving. I underestimated, in fact, how much of a trigger that was for people leaving. So the Christmas tree model is probably one that we need to relook at, and certainly in other professions we wouldn't use a Christmas tree. What we would use is differently skilled professionals all working together to redistribute workload. And that's all the things we would look at. So we would look at that kind of work before we started thinking about numbers. And when we understood all of those things, that would help us understand demand for labour, and also the types and skills of labour. This kind of work is safety critical, so it's not just about task completion. You have to be able to apply the knowledge and skills in different situations. And that's when we would start to think of numbers. So we do all that work before we even thought about an establishment. Once you've done that, then you can start to really build your model and look at how many people you might need, what kinds of people you might need, how experienced they might be, because we, in safety critical industries, we do use things like rookie factors. So very, very newly qualified people expend more effort and labour and take longer to do things because they're working to an algorithm in their head before they develop workforce proficiency. If you watch an experienced person work, you'll never be able to work out what they're doing, because they just do it. If you watch a newly qualified person work, you can quite often see the cogs turning and follow the steps that they're following. So it's things like that we would think of when we were thinking about a demand model. And the last thing I'd say is we talk about safe staffing, but what is safe? So that's something that I think each different type of practice, whether it's general practice, community nursing, district nursing, community hospitals, acute hospitals, needs to grapple with. It's a bit of an elephant in the room. What do we mean by safe? Do we mean just not causing harm? So that's safety one, the things that Helen talked about there. Or is it that actually we want a safety culture, we want people to be happy at work and joyous at work, and we want people to have therapeutic relationships with patients, and we need that level of labour and to provide psychological safety. So I think I've rambled on for quite a bit. So I'd be really happy to answer any questions.
Sorry, helps if I could find my mouse to unmute. Thank you, Alison. That was really fascinating. And I think, well, I don't think I'd thought about that definition of what is safe. I think we start from the place of feeling like there should be a magic number, and we should be able to put some numbers into a nice equation and come out with, I need this many RNs and I need this many healthcare assistants, or whatever that is. So I think that's a really, really fascinating concept to think about as a starting point. So I'd really like to open it up for questions, or if you've got examples of good practice from where you work that you'd like to share, comments, whatever. So either pop your question in the chat box if you want to, or put your hand up. So Lynn, I can see you've got your hand up, so over to you.
Can you hear me? Thank you both for really interesting introductions, and I've written lots of notes because I'm actually currently, I work as an advanced nurse practitioner in community hospitals in Leicestershire and have done for 10 years, and I've been a ward sister before that in community hospitals. So I've been in community hospitals for quite a while. And I'm in the middle of writing a report and a proposal, if you like, about our staffing, because I think there's definitely a lack of recognition about the complexity of our older people. So when I first did my advanced practice, I started 10 years ago, the patients are a lot sicker and older now with multiple complexities compared to how they were 10 years ago. So I'm actually looking at, yes, we've got advanced practice, but actually we probably need some more consultant practitioners involved because they have that expert knowledge and experience. And we also have the consultant geriatricians, but also about the lack of recognition of the importance of rehabilitation in these patients as well, which would also go some way to improving some of the social care issues if people actually received decent rehabilitation. And that all leads into safety of patient care. I feel a lot of discharges are rushed because there's pressure from the acute. And a lot of these people are living with frailty. And the other thing about community hospitals is that what we do in Leicestershire is apparently quite unique in that we deal with an awful lot of sick people and we don't send an awful lot into the acute. But there's no standard across, certainly England, for what community hospitals do, what sort of patients we take. And so comparing like for like is really difficult when it comes to patient safety and staffing levels as well. So I'd be really grateful to hear your thoughts on how we can, move these things forward and actually recognise about the fact that quite often there are registered nurses on the wards making key decisions when there's no medical staff, and they are band 5s and yet making really high level decisions that some other band 5 nurses elsewhere don't have that responsibility to make.
Alison, do you want to?
Sure, yeah. I mean, for a start, if band 5s are doing that on the ward, I mean, they should go to the RCN and get job matched because they're being underpaid. It's the first thing I'd say. And because, retention is the name of the game now, really. I know politically it's all about recruitment and supply, but you've got to keep people. It's the only way that we're going to get through this, actually, is retention. there is a lack of consistency, and that actually goes through most sectors. So there are some commonalities around work and demand for work, but there's nothing wrong with a local workforce plan if it works for you. So, and generally where we see this globally, where you see a workforce model globally, and the most common ones are ratios, they're a fail-safe, they're what you should not go below. So the district nursing modelling is that, it's what you should not go below. It's not a model, as it were. And in most safety critical industries, what you would have is a minimum. You would have a don't go below this or you're getting into deep water. But then it's up to you to decide what's actually required for your service. So in the airline industry, there is a minimum crew. But the different airlines, depending on the level of service they want to give and the level of sort of satisfaction they want to give, will staff differently. And that's kind of one of the principles of safety critical workforce modelling. There is always a red line. And that's what's missing in healthcare. So it might be worth thinking about where your red line might be, where your big areas of risk are, because your workforce is your principal risk managing mechanism. It's the thing that manages most risks. Lots of people think it's policies and procedures, but actually it's your workforce that manages risk day to day. So I don't know if that answers your question.
It does. Thank you ever so much. Really appreciate it.
Can I add to that? Not on the detail, but I think I went to a round table a couple of weeks ago that Health Service Journal did. It's not been published yet, and it was looking at virtual wards. And what, yes, and oh yes, and what struck me from that conversation was everyone uses the same phrase for about, I don't know, probably 15 different definitions of what that means, but also that that our what we're doing is robbing Peter to pay Paul. So we've got different incentives and mechanisms. So you know the whole point of and the challenge with a non-hospital environment is these things aren't particularly visible. So if it's all about discharging from hospitals, it's managing, you know, acute sector demand, and it's putting services out into community hospitals, then effectively, Lynn, what you're saying is that, you know, patient acuity and maybe volumes are increasing over time, and that's not recognised. So I think the approach you're adopting to being very explicit about the assumptions of what staffing you need in order to provide the level of service that you want to provide, and to be able to monitor that over time, because the demands are coming in a way that is you're less able to control. You're in receipt of those and you're having to respond, and as Alison said, it's not policies that will manage the risk, it's people. And the risk of that is that it'll be people that won't have the capacity, won't have the time, maybe not have the skills, being asked to work outside of their areas of comfort, their knowledge. And that will put more pressure on them individually, which is very uncomfortable. But also it means that in terms of service planning, you're being dumped on. And so I think it is always being much more explicit about the assumptions on which you're managing a service and what capacity you need to do it, and then to use that as a mechanism for reporting back. I don't know whether the ICSs, the ICBs, the ICSs are expressing interest in this area, but if there is such an opportunity for them to be able to get into this and make sure that you're not just moving the problem around and particularly to an area that's less visible, I would hope that ICBs and the ICS partners would really want to really grab these issues. I don't know, Alison, whether ICBs are beginning to pick this up.
Yeah, I think, to be honest, I mean, I think ICBs struggle in the same way that CCT struggled, that, because there's no sort of magic number, and people do really want a formula. they end up leaving a vacuum, and then the vacuum gets filled with different types of workforce. So one of the ones that what we see a lot of now is invent a new job. So there's an old problem that people can't solve, so we invent a new job, and the job doesn't end up being sustainable. And it's why we've got 77,000 different job titles in the NHS. So you know, physicians associates, ACPs, a myriad of different therapy people, and it's not that those roles don't have value. It's just that they're quite often gap fillers, and being a gap filler is not a good idea in healthcare, in any industry actually, for a number of different reasons. You've got to determine your jurisdiction. You have to go through a huge amount of work. So but that seems to be the default now in terms of workforce. It's just invent a new job. But if you don't solve the old problem, if you don't find out why people are leaving, if you don't find out why, you know, you can't attract people and do something about that, then that is literally filling the leaky bucket.
Kirsty, I know you've got your hand up, but Helen's posted something in the chat box that I think is just really relevant now. So she said, thank you for a great presentation. She's currently writing a safer staffing review, gathering lots of info, staff feedback, current working patterns and establishments, safe care data, etc., but struggling with the so what and how to convert this into a number, which is what she believes her seniors are expecting from her report. So she's just said help. And also registered nursing associates, where do they fit in registered nursing numbers? Much debate.
Yeah, I mean, so what we do, well, what we've done locally for people is then you look at outcomes. You look at, you know, and that can range from everything from length of stay to survival. And then you can understand the relationship. So what we usually find in nursing is there's this like S-shaped curve where you've got lots of people experiencing falls, poorly controlled symptoms, whatever. You add more registered nurses. Now, I must emphasize this is graduate registered nurses or people with 10 years experience. And then all those things fall off. And then adding more people makes no difference after that. So there's this like sweet spot. Registered nursing associates are an unknown quantity at the moment. The line of the RCN and even the CNO's office is they're not meant to be used to substitute registered nurses. I know they are, because a lot of them message me about it. But what we're seeing with the registered nursing associate is that, so their education program is about delivering and monitoring. They are not trained to assess patients and they are not trained to evaluate care. It's not in their NMC scope of practice. So when they are asked to do this, things can sort of unravel a bit. And that's what we're seeing. That's what we see anecdotally. So the RNAs doing, you know, delivery and monitoring of probably high volume, low risk work is actually a really good thing. It probably will help with labour. Asking them to work out of scope, it's like asking anyone to work out of scope, then you're into sticky water, really. It's very tricky for them because unless they get onto the RM programs, they were designed as what we call a terminal career. That's it. You're stuck in that job. And when people get stuck in jobs or have expectations of moving out of that work, and there's some research going on about this at the minute, because there's been quite a low conversion rate of RNA to RN until hopefully now, because they've put some more money in, HE have put some more money in. But what you see is a really discontented workforce because their expectations are not being met. And discontented workforces can burn out. And this is the thing about new jobs not solving our problems. So they shouldn't be used to substitute. They feel exploited when they are. We do know that. That's very clearly emerging. And also because they are in a delegated role, it puts more pressure on registered nurses to supervise them. But then if they're given the work that they are in scope for, they can contribute to labour demand. So I don't know if that answers the question. It's quite early to say. So.
Helen, did you want to add anything? Helen Hunt?
Hi, thank you. Actually, that does help a lot. And it isn't just an interesting note, because I think we've got both. We've got RNAs who are absolutely highly capable and able to take on the less complex, and and are supported to do the don't do the assessments but do everything else. We have recently changed slightly to ensure that we've got more registered nurses on shift, and what we're finding is that they, in their words, are being demoted to a healthcare assistant and now are choosing to leave because they're not using their scope. And I think it's really, we've got both. We've got ones that want to, we're happy to sit, others who feel demoted if we've got too many registered nurses on because we're not allocating them work.
That's the first time anyone's ever said that.
Yeah.
I've literally 15 years never heard anyone say that.
Okay. Well, that's definitely.
Brilliant.
I think it's because we've changed. So we had a decision was made by our chief nurse to make some changes, and I think what that showed to us was the difference in practice that we were doing in, let's say, phase 1 and now phase 2. Right. We've changed it, and therefore it's that change that is the challenge, really.
Yeah. I mean, nursing is more technical. And so I think some groups' expectations are changing of what nursing is. And less probably person-centred and holistic, because that's what people have been exposed to now.
I think it's quite a sad reflection, really.
Yeah.
Just on a kind of similar theme from Alexandra, and she's specifically to you, Alison, do you have any thoughts on using establishment setting tools in community hospitals, such as the SNCT, which I think is Shelford, isn't it? Mindful that the tool was researched in acute care.
Yeah, so the SNCT was researched in acute care, and Keith Hurst developed it over 30 years. I mean, it's a fairly well-established tool. It tends to underestimate workloads in perhaps like care of the elderly or longer term conditions. It's more geared to, I think they were going to look at it again, look at the sort of the multipliers, because it's an arithmetical tool. It's a bit of arithmetic, really. And they were looking at the sort of the multipliers so it used to be that if you had someone, say, that didn't need lots of IVs but had dementia and needed a lot of care, they would show up as low dependency. Even though they took up a lot of labour, their acuity score, if you like, was quite low. And I know they were going to look at all of that, because that was obviously, as more people needed more input, that was one of the things I know that they were going to look at. So I just have some caution around that. I just check that, given your likely client base, that it is actually suitable. And also the complexity of work. It doesn't reflect the complexity. So one of the ways we know that it perhaps underestimates work is we say nursing is a profession of vigilance. In that if you are a nurse, you're not only doing things, but you're watching. You've got skilled eyes that watch for stuff all the time, like air traffic control. And that also uses cognitive labour. So detection of deterioration being one of them. it doesn't sort of account for that kind of demand. So it's just, so we know a lot about SNCT, but we know a lot about where it underestimates. So it's really relatively easy to uplift. So I'd just be careful that it meets all the requirements. There are other tools, so things like Establishment Genie, which is used in areas like hospice care, which is NICE approved, is also another tool that you might want to look at. I don't know if there are plans to develop SNCT for community hospitals either.
Thanks, Alison. I'm not aware that there are any to develop it. Establishment Genie also has some quirks and isn't
it does.
completely
They all have
transferable.
quirks.
They all do, don't they?
That's why professional judgment is so important in staffing. You know, you can a staffing model is a guide. It's not a. It should come down to professional judgment at the end of the day.
And I think there's a bit of a theme in the chat around data and are we collecting the right data? And lots of that's in terms of how we define, and then we come to acuity, complexity, dependency, and the difference between those three. But they talked about things like delirium prevalence, which can be up to 60% in post-acute settings. And Rob, I think you've made a really good point around whether it's the kind of safe skill mix we need to talk about. So I don't know if you want to elaborate a bit on that. I'm putting you on the spot now, Rob.
Hi, no, that's absolutely fine. And I just asked another question. I know we want a magic, what we operate currently on magic number, isn't it? You need so many RNs to so many beds, so many patients, whichever it is. But actually listening to, I think it was Lynn and then Helen, do we need to look rather than consistent number for every unit, recognizing the different populations, different localities? Actually, we should be looking actually for that local population in Lynn. I'm not sure. Did you say you Leicester? I think, you know, in Leicester, we don't need 1 RN to 5 patients. We actually need 10 RNs or whatever the number is. But actually in West Sussex, where I am, it needs to be different, and the skill mix needs to be different. Maybe we need more ACPs or ANPs, whichever, and do it on this basis. I suppose the challenge is you still need a bit of a framework, because we still need, which I think Alison you said too, we still need that minimum. What is that minimum? So, you know, airports, not airports, airlines, they have 3 as a minimum. You always need this, but then how you mix it up. And I think that's a cultural change to some of the senior people as well. So I wish I had an answer. I don't, but hopefully I provoked some thinking. And my other comment was, I agree with professional judgment. I have a privilege of working with some excellent nurses and ACPs where I am. And I know that probably if I ask 2 of the matrons to look at what's the staffing level today, they will have a slightly different view. So, because they have slightly different risk tolerance and slightly different bias. So how do we remove that as well?
That's why you have a bottom line, so that somebody who's very, very high risk appetite doesn't. But the red lines depend on what you consider safe. So you need a consensus about what is safe for you. So district nurses, with the modelling with district nursing, it was about what they considered safe before we could do the red lines, the safety rails, the places where you shouldn't go. And then, then you can build on that. So most workforce modelling is iterative. So in the airline industry, the minimum for an Airbus is like 3. That's to evacuate the plane. That's their line on safety. How many people do I need to get people off this plane? That's their line. So understanding where your line is as a community. So are you going to include delirium? Is that a big pull on labour? What are those things? Once you've worked those out, it's a lot easier then to think about a workforce model. Oh, sorry, Helen's got a hand up. Sorry. barged in there.
That's all right. No, I've got a question actually, which is how do you all know what each other's doing? So if everyone's developing their own approaches, and you know Robert's point about different levels of professional judgment and how important that is, but is there a kind of, other than through the research work that Alison and other colleagues do, how do you know what's happening? Do you share each other's experience? Do you feed that back? I mean, how do you find out?
Lynn?
I'm a member of the British Geriatric Society, and I sit on the Nurses and Allied Health Professionals Committee, and that's where I share what's going on and hear stuff back, and also I also sit in the England Region Council of the British Geriatric Society, and that's how I find out what's happening elsewhere in the acute and also the community, and that's how I know that it's very different across the whole country. And sometimes some areas do some really good work, and it's like, oh, actually, have you heard what they're doing in the south? And what they've done with consultant level practice has been fantastic in their community hospitals, but also in the community, and so it's shared. But there isn't a sort of national. There is the community hospitals group on Twitter, but I don't know of anything sort of more formal that could be like us here. This is great, having a discussion about how things are happening here with workforce and the issues. So I think that's how we share things. But I don't know about the rest of you, but a lot of our managers, they will only work to the bottom line, and even then it's stretched to the point that, yes, I'm a registered nurse, but I work at advanced practice. And I challenged a couple of weeks ago about our registered nursing associate, who is absolutely outstanding. I was like, no, she cannot be the second trained on the ward. She has to be the third. And if I hadn't gone, actually, this is unacceptable and it's not safe for her or the patient, then that would have happened. And it's having the guts to actually challenge that level of that things that are happening, to then people go, do you know what, I feel safe where I'm working. And it's like you said earlier about, actually it's the retention of staff and developing staff and making them feel safe when they're at work. And they're the key issues that we're facing nationally, as obviously as well as pay, but it's about feeling safe when you're at work and that you're actually able to deliver really good care with an advancing aging population that's more and more complex.
Thank you, Lynn. One of the things is that we did invite somebody from the Chief Nursing Officer office to join us tonight, but there wasn't anybody available. But I'm lucky enough to have half an hour with Ruth May later in the month to talk about community hospitals. So one of the things I am going to do is reflect back the themes from tonight as part of that conversation. And actually, maybe it is that networking that is going to be one of the more valuable things. And CHA in itself would love to be part of being able to enable that, but it also needs to work for across the 4 nations, and it needs to work for those that are independent community hospitals or charities and not part of the NHS as well. Can I come to Kirsty and then I'll come back to you, Helen? Is that okay? Because Kirsty had her hand up ages ago.
Hi, yeah, I think maybe you mentioned what I was going to ask about, because I'm a GP. I hear my colleagues talking about safer staffing conversations quite frequently when they call it a safer staffing kind of meeting, I think, that they have either every day or every week about the staff on the ward. But one of my colleagues did an audit because there's a particular issue with one ward at one of the hospitals that I work with, and it's just been a long running issue and nobody really knows why. They turn over the staff and they're not sure. But when she actually did a deeper dive into what was happening on the ward, she realized there was I don't know what it was, maybe a lot of extra activity going on. They were having a lot more patients moved there and back again, and actually maybe the acuity of the patients was higher, and also they have a palliative care bit on that ward, which again requires a different set of skills, but can be more intensive, but in different ways. And I think I was thinking, well, is there not an equation that kind of measures all these kind of differences? But I think you mentioned it, Evelyn. It was they've tried to, is that right? They've tried to come up with some equations, and yeah, but it's I suppose it highlights, what it highlights is the community hospitals have, even within a community hospital, and all community hospitals can be quite different. There are, even within the wards of a community hospital, there are very different stresses and demands on the nurses, which make I suppose it difficult to decide on the staffing levels, maybe on even on a day-to-day basis. So I could see that it's really difficult. Yeah, sorry, I'm just rambling now.
And I think that's the thing, isn't it? Everybody wants that magic equation, and it doesn't exist, I think, is probably what we're all agreeing. Helen Hughes, you had your hand up a minute ago.
Oh, me? No,
Yeah.
no, that was me asking the question.
Okay. Can I ask a question, and then I'll come back to some more of the comments in the box. But if you know, somebody who's a matron or a ward manager or is looking at safer staffing for their unit, what is the kind of data set they should be looking at in order to be able to quantify some of this? Because we're not going to be able to get away from numbers to purely, you know, professional opinion. So is there a consensus on the data set that we should be starting with?
Not in community hospitals that I know of, no. So we do have them in specialisms. So a lot of the workforce modelling we've done with numbers is to do with specialisms, because specialisms have very good data in terms of registries. So, you know, I can model the inflammatory bowel disease workforce. We're currently modelling the haematology workforce. They have a lot of data in terms of their detailed data in terms of their clinical work, and also things like their service work, and then we add sort of uplifts to that. So while there's no equation, there is a coefficient. There is a thing about complexity and how we can think about complexity in terms of some mathematical rules. It's like that S-shaped curve and things like that. So once you know what kind of, and the reason they've got those registers is because they focus on outcomes. So professional groups, charities tend to focus on outcomes. Macmillan, the haematology, British Society of Haematology, the Crohn's and Colitis UK, they have outcomes, what they want. They have certain things that they want in terms of quality, safety and efficiency, and that's how we evaluate workforces: quality, safety and efficiency. NHS organisations tend to just focus on efficiency. So they'll always want to know, does it reduce length of stay? Does it reduce rates of readmission? Does it produce admission avoidance? Because the acute bed is the most precious resource in the NHS. So it very much focuses on that, but you might have different outcomes. So once you've got the thing you want to achieve, is it that actually, and we're actually doing a project in Norfolk and Waveney at the moment, with some of the acute hospitals, looking at the reintroduction of therapeutic nursing care, NDUs, if anyone remembers those. To see if it does do things like reduce length of stay and you know, people don't decondition, basically. It's that sort of thing. So once you know what your outcomes are, and once you've figured out what safe is, then you can start thinking about your numbers and what patterns in the numbers you can look for and what you can find. The data, a lot of people put really good things in the data in the chat box around data. So yeah, if people with delirium are taking up a lot of labour, then yeah, absolutely should look at delirium. Certainly in district nursing, the people that used a lot of district nursing labour were people over the age of 85 with multiple conditions, and people receiving end-of-life care. So you've got those. So as a modeller, I've got those things to hook onto straight away. I've got ONS data, which is really reliable. I've got data from the workforce, which is probably a bit more interpretive, but still good. and then I can work back from there to think about numbers. So only you understand your work. As a modeler, I wouldn't understand your work. Only you understand your work.
And I guess a question to the others in the group is this somewhere where community hospitals can do something very different by looking at the MDT in its broadest sense? Because I think rehabilitation and that enablement is a key thing that goes on in community hospitals. So actually, is there a different, safer staffing in terms of skill mix and skills around community hospital that is far more integrated in MDT? Don't have an answer, but it feels like there should be. Lynn, you've got your hand up.
I know I should be quiet at some point. I have this thing in my head that if just for like you mentioned nursing development units. And when I first qualified, Alison, sorry, when I first qualified, the ward that I worked on had been all set up to become a nursing development unit, but they didn't get the funding for it.
Oh.
So we had, what we did so it's obviously centuries ago, I delivered the care as a registered nurse. I did everything for those patients, and the nursing assistant assisted me to deliver that care. So I literally assessed them head to toe. And I'm of the, yes, it does take a registered nurse to wash a patient school, because it does, because it's a full assessment. And even in advanced practice, if I had the time to wash patients, I would, because they would have a complete assessment. But going back to nursing development unit, what if we were able to have an experimental ward like the one I'm working on at the moment, whereby it's staffed with registered nurses only? They deliver everything, and you still have your occupational therapist and your physiotherapist, but everybody's registered. And I'm not decrying unregistered staff, but it would be able to demonstrate the quality of care that is delivered by registered staff, and actually the value of nursing. And quite often nursing isn't valued, and other people think that they can do the jobs of nurses, and they can't. And then from there go, actually, well, does it take a registered nurse to do that? No, it doesn't. And then you can start picking things off. So if you start at the top, and it's like your Christmas tree that you mentioned at the beginning, that you could actually do that, but it's like, who's going to fund it and all those things? But can you imagine the level of amazing care the patients would get?
Yes,
it would be wonderful.
You know, that's what the evidence says. The evidence says that care is safer, as in survival and outcomes, when registered nurses are delivering care. They're more likely to detect deterioration, and they're more likely to act on things that's rescue work. You know, call it rescue work. Well, Silber calls it rescue work. And so, yes, and I mean, there's nearly 1,000 papers now that show that relationship in some form. And certainly adding other people in is advantageous. So when you've got models where you've got care of older people, and you have an OT as part of the establishment, or a respiratory ward, you've got a physio as part of the establishment, then you see good outcomes, you know. But they are registered healthcare professionals generally, so you can mix the skill up. You can mix the not the skill level, but the praxis, the different lenses, different professional lenses. You can mix those up, and it's probably advantageous, yes. But the issue is, and this might be quite controversial, let nursing go. So now we do have people, and I'm not going to use the term too posh to wash, but people who have different expectations of work now and don't understand that really, really important part of nursing because they've never seen it. So, yeah.
Thanks, Alison. Helen?
Yeah, it was just a reflection back on that comparison that you made, Alison, about kind of the NHS focusing predominantly on efficiency and not looking at quality and safety. And because if people aren't defining what they want in terms of outcomes for quality and safety, then if there's a degradation in the performance, it's invisible. So I think that's the challenge, is to be able to demonstrate what impact that is going to have on the quality and safety of care, also the quality and safety of staff and their well-being, and some sort of quantification of that. Because if it's just about efficiency, if it's just about throughput or these kind of very blunt metrics, then it's much more difficult to argue the very coherent case that you've made there, Lynn, about, you know, putting quality at the top. And, you know, quality and safety are seen as the bit that gets squeezed when you don't have enough money. And it's being much more explicit about that, I think.
And I think community hospitals, because we see the questions we get asked, we see the blogs that people write for us about the great innovation, we see all of the entries we get for innovation and best practice on an annual basis. You know, we saw the work that was done through COVID when we carried out the study. So I think community hospitals in general have a really keen focus on those three key aspects. So they are really focused on the quality, then the safety, as well as the efficiency. So I think that's probably partly why this is such a complicated thing for people to grapple with, because they really are trying to do that whole approach. Rob, you've got your hand up.
Yes, it's a slightly different question about the safe staffing. I hope people don't mind me moving to a different question, but where does the patient or the people who know the patients probably better, families and carers, where do they come in developing or implementing safe staffing numbers? And again, sorry, it's a question rather than an answer. But
so I don't think it currently in policy. So I'm not sure about SNCT or any of the sort of the things that come from the arm's length bodies. Certainly, most people I know would use customer experience as important in workforce. So whether they're customers, patients, or because it's a bit of a peculiar one for me, because I work in areas like retail, grocery, and other safety critical industries, and customer intelligence, people go out of their way to collect it. I mean, it's really valuable. But in healthcare, it's kind of like mostly disregarded and seen as a sort of an extra. Certainly in the modelling we do, we have patients that co-produce the models with us. Mm. And if you look at our papers, we'll have patients as researchers, authors on the papers. Yeah. So, yeah, I mean, to me, it's, you know, in the world of commercial modelling, the people that are going to use the service. So when we think about labour, we're not just thinking about the labour of the paid workforce, we think about the labour of the people using the service as well. So if you use a self-service checkout, you know, in a supermarket, you've become part of the workforce. You're giving your labour to that organisation where it once would have had to pay someone to do that.
Yeah, it's really, really helpful. And the reason I'm just asking, because, you know, the unpaid carers, so very often, you know, relatives or your next of whatever it is, they know you best. And actually they can really, whether we like it or not, whether it's right or not, we can have a separate discussion, but they probably are part of the safe staffing, or should be part of safe staffing consideration. And again, maybe it's different in every hospital or locality. Thank you.
Yeah, I mean, certainly in cancer, most of the cancer modelling we've done, we've relied heavily on cancer patient experience and, you know, different aspects of using services. So yeah, absolutely.
And Kirsty's just reminded us about SNAP audits for stroke rehab, and we know there's quite a lot of stroke rehab goes on in community hospitals. So it's kind of another area, and it looks quite differently at the requirements, doesn't it? And it's quite prescriptive in terms of what patients should have, the best practice. Lynn.
Yeah, I've been pestering for about, I don't know, 18 months to have a PPI group for our community hospitals, because how can we implement policies and things that are demanded of us if we don't actually know if that's important to older people? But also our head of nursing is actively inviting patients, relatives, public who have an interest to come and help shape our nursing priorities. Because if you don't involve, like, you know, you've said, Alison, if you don't involve the people that are actually using the service, how are you going to know what it's like? And, you know, round the table tonight, none of us know what it's like being an older person. So so we need to be involving them in what we're doing. But actually, it's really, really difficult to get the big machines of organisations on board with this. So I've been going on about it for 18 months, and finally something's happening. It's slow, but it's one of those things that you have to chip away at.
Dan, you had posted some questions earlier on, which I wasn't ignoring, but the conversation took us elsewhere, about whether we were relaxing our kind of metrics around things like pressure areas in terms of safer staffing by saying things were, or by allowing us to say things like pressure damage is unavoidable. I didn't know if you had a question you wanted to pose.
No, I just think it's a comment really about what we've heard from both speakers, reflecting on that definition of safety and the link with workforce. So I don't know. I mean, Evelyn, you know better probably working in the hospice world, where you tend to have a richer skill mix than we do in our community hospitals. Whether your definition of what's avoidable and unavoidable is different from somewhere where we have less staff and therefore make excuses.
Yeah, I think we probably all work to the same definition. I think we do have a richer workforce, and that allows us to work differently. But we still struggle with the skill mix issue. But we also have a smaller cohort of patients and not quite the same pressure on throughput. So, you know, it's different. It comes back to context again, doesn't it? You know, we're probably spending a far greater time with families and carers as well as the patient. So you can't really compare the two workloads. But I think the definitions are pretty standard. We use the same definitions as the NHS. So,
and would that definition be the same anywhere in the world where they have better staffing levels? Would we still have the same numbers of unavoidable pressure ulcers? I don't know really.
No, and I think that's the problem, is finding the data that you can compare. So, you know, the NHS benchmarking does some great stuff, but it's quite focused on numbers, isn't it, and throughput and input. So, you know, it doesn't help with that kind of softer quality intelligence stuff.
Thank you.
Thanks, Jan. Is there anybody who hasn't had an opportunity to say anything, who's got a question or wants to pop something in the chat box? I'm just conscious we're getting close to 8:30.
I think just to say Sarah's comment there at the end, that's completely true, because there's some really nice studies on the environment and the effect it has on labour usage. So yeah, and single rooms as well require more labour. So yeah, I see, and there are all these factors. This is why there's no simple equation.
Yeah, I oversee 2 community hospitals in Cornwall, and one, you know, we actively use our meaningful activity coordinators and can do Baywatch, so we can reduce the amount of staff compared to what I would need in the other community hospital because of the layout. So for me, you could have the same patients requiring the same care needs, but I can move the staff around because of the environment factors.
Yeah.
And I think there's some great resources, Alison and Helen, that you've pointed us to. So we'll try and gather as many of those as we can, and the stuff that's been in the chat box. And we're going to pull together a resource pack following this that we'll share with everybody who's been here tonight as well. So with some of the learning from the COVID project we did, because I think this is a really important piece of work. And I'm hoping this will be a starter conversation and that there are more to come. Helen?
Yeah, it just strikes me that there's such insight and wisdom, I mean, in this group. And if you've got an ambition of sharing and developing good practice, that could, you know, particularly with your Bending Ruth May's ear in a few weeks' time, you know, developing this into something that you're never going to get that magic ratio. That's a sort of false ambition in a way. But having these kind of frameworks that you can share learning from each other and take that into account, you know, like that super example that Sarah's just given about the physical layout and the impact it has. So it's kind of whether you use this excellent kind of discussion to create something, you know, a network that actually develops this a bit more.
Yeah,
Why not?
I think that's part of the conversation with Ruth, but also for us to test out with members whether that's something that we can facilitate, at least as an interim, and start connecting people in a different way that allows you to do more sharing directly with each other, really. And I think we've been talking about a kind of matrons network and whether that's something we can test out. So if any of you would be interested in helping us to think that through, just
I'm really
something in the
sorry.
chat box.
I'm going to have to leave because I'm going to get locked into the university in a minute.
Thank you so much, Alison. It's been fabulous to have you. We really appreciate your time.
No, but you've got my contact details. So if anyone does have anything else, then please, yeah, do get in touch.
Brilliant. But go before you get locked in.
Yeah, I better get locked in. They're going to put the alarm on, so.
Thanks, Alison.
See you then. Bye-bye.
Well, if nobody else has got anything else, then I'd just like to say thank you all very much. It's been a really interesting discussion. I hope it's been helpful for all of you. And we would really appreciate your feedback, because this is the first time we've done something on this topic. So yeah, it's been a real pleasure, and thank you to Alison and in particular Helen, you who've been really poorly and still came up tonight and did a great presentation. And I think it was really important that we had both sides of it. I think that was a really important thing to do. So yeah, and we'd love to have you back, but it would be great. Yeah, we'd love if you would be keen to be part of us trying to help us set up a network.
And we, as you know, we support lots of networks, and that's kind of what we want to do at Patient Safety Learning. If we can use our capacity to do that, then let's have a conversation about how we could take that forward. We'd be delighted to help.
That would be brilliant. Thank you, Helen. So from me and the CHA and Q, thank you very much for attending tonight. We will be in touch. So you'll get an email from Q with the link to the recording. You'll get some contact from Eleanor with your certificate. Both will probably tell you how you can join our SIG, our special interest group. And we will make sure that we keep this as a mailing list, and we'll update you after our conversation with Ruth, and we'll progress some of those conversations. So if that's okay, we'll kind of use this as a starter group for progressing some of that work. But thank you all very, very much, and good night.
Thank you.